Hi, morning guys. How are you?
Morning, Doc.
All good.
All good. Excellent. I'm happy to hear that. You're not going crazy, are you?
Oh, absolutely.
Say again.
Absolutely. But we've accepted it, so it's good.
All right. Well, hopefully we can do something to allay your fears in this session, or perhaps push you over the edge. I don't know yet. We'll have to wait and see. I see some persons are still coming on, so let's give them a couple minutes and then we can get started in 2 minutes. All righty.
Recording in progress.
All right, so let's begin. Guys, are you hearing me clearly?
Yes, sir.
Excellent. All right, so I hope to go on for maybe an hour, hour and a half, 2, 3, 4 hours. Not sure how long it will take us to get through this session. What is important is at the end of it, you have a better understanding and a ready understanding and an examined understanding of aspects of breast cancer and some limited aspects of benign breast disease. I'm not going to go all in on benign breast disease, but I will be able to answer your questions on the matter if you have specific issues on it. Obviously, I can't review the entire syllabus, but what I want to do is to just give you some relevant pointers as you approach this very critical juncture in your course. All right, so what I want to encourage you to do is to just shout out when you have an issue. It's a very informal session, tutorial, if you will. So just shout out whatever you want to shout out, streams of consciousness when you have a thought, so the rest of us can share from sharing and gain from your experience and your thoughts on the matter. All right, so don't feel any way about just interrupting me. What I want to make sure at the end of the day, last read, if you haven't done it already, you're good, you're set, you're ready to go with this topic. All right, everybody on board?
Yes, sir.
All right, cool. At least one person is on board. Let me just take off my camera a little bit to get some more bandwidth. But if you need to see my face, just shout and I'll show you my face again. I'm sadistic like that. All right, so we're going to look a little bit on breast cancer and some aspects of benign breast diseases. And I think it's useful. I did this in the last review. Yes?
Babe.
Somebody have a question
Babe.
already?
Turn off my battery tonight.
Oh, okay. Okay, Dave, close your mic. Oh, first slide and they have questions. This is incredible. It's gonna take 3 hours.
Turn off your battery tonight.
All right. So this is what happened in January of 2022. I put this slide up here really just to scare people into knowing that, you know, there are some challenges associated with the conduct of MBBS examinations. Sometimes we had in this one in January, online only examination, and we had a massive
Why
failure
you calling me?
Okay, a massive failure rate of about 42%. I put this there really just to scare you, because it was a bit of an outlier. If you go back over the years, our failure rate is generally less than 15%, and certainly not over the alarming 25% that the university often uses to trigger negative assessment of an entire program. So we usually are very concerned anytime it goes over about 15%. So that was a bit of an outlier. And it turned out that although the numbers are small, so they're a bit unstable, the MONA students featured prominently in the very high failure rate that was experienced in that particular examination. And what is more is that the failure rate was even more than we would have expected, given that the other specialties, medicine, ONG, and so on, had reasonably legal failure rates. So that was a bit of a concern for the faculty. And so we had to conduct some kind of analysis to see what on earth was really going on. So what we heard from the students was that there were some challenges. Part of it was that some of the students were part-time and doing other jobs as pharmacists and physical therapists and business persons, and not particularly engaged with the faculty, and definitely not engaged with each other, with their fellow students. And therefore, some of them ended up going down some rabbit holes. They ended up studying material that was not recommended by the faculty, older text, older sources of information, notes from other people that wasn't updated, and therefore they ended up being trapped in the silo of their own examination, of their own information system. Other students had a lot of problems with how the questions were designed. The newer MCQ, more modern MCQs, tend to test a greater level of understanding than just knowledge, testing some amount of understanding. And therefore, some of the questions are about the background, so the stems are a bit bulky, and therefore difficult to get through in the requisite 86 seconds that you have to respond to a question. And so they ran out of time. A lot of these questions were based in a clinical way, and because the students were not engaged with the clinical spaces, they had a challenge just kind of understanding the mind of the examiner who was writing the question. So what would be seen as quite intuitive to a person who is in the clinical space became very difficult for the student. And then, of course, the students also reported that the faculty was just not particularly engaged with them. Structured reviews were not as fluent, not as plentiful, and the reviews were not particularly oriented to the examination that the student was taking. It was more a review of the topic in the usual way, without reference to the exam that was coming up. Now, the purists will say that, we don't prepare students for exam, we prepare them for life, and therefore, once you prepare them for life, they should do well in the exam. We can argue about that, but certainly that was the feedback of the student, that the review was not particularly useful. So that's the background that I'm approaching this particular session with, trying to redress, if you will, some of the deficiencies in the student perception of the department performance and the student performance in preparing for this particular topic and this particular MBBS examination. So breast cancer is that, right? Obvious, something is not right with the breast, ulceration, satellite lesion, matted, ulcerating nose. And if this is how breast cancer presented, then, well, life would be easy. It would be easy for anybody, including a man on a galloping horse, to be able to recognize that there's a problem and therefore deal with it. But that's not really how it looks, nor is this how it looks. And this is more how it looks. Will you agree with me? Sure, he says. So,
that the pathology is not obvious.
Well, this is the mental picture of it. This is when I went to Haiti in, I think it was 2010, in the wake of the massive earthquake there. 300,000 people dead and the whole place devastated and in shambles. I think this was a presidential palace. And this is how, in interacting with my patients, they have the impression of the course of their life. It was an utter collapse of their proud assets, but just, their entire psyche will be impacted negatively by the diagnosis of breast cancer. And so we have to take that into account as we approach a patient with breast cancer. How do we manage the whole situation and the whole anxiety that would have been built up because of all maybe talk about breast cancer and death from it? So what we aim to do in this session is provide you with something relevant to the exam. We want to talk about the scope of the problem. We want to define it. We want to go through a process of how we come to a diagnosis. We want to look at some treatment options with a focus on surgery. And then also restoration post-surgery. If we have time, we can get into a little bit of the preventative aspect of breast cancer, if there's such a thing. But I want to start in keeping with the concern of the student with some multiple choice examination questions. So this is an example of an easy multiple choice examination question. Who wants to answer this question? Come now, guys. It's early in the morning. I'll fall asleep if you're not engaging with me. Matthew.
All right, Doc, I think A is the option.
A is the option. Does anybody have an alternate option? Let's see. Okay. So, okay. So there are a few options. Okay. So I see A, I see D, I see B, I see no. I see B, I see B. All right. Let's look at this. Sorry. Let's look at this. So this is supposed to be an example of sorry, I went too far, of an easy multiple choice examination question. Which of the following is true of breast cancer? The lifetime risk for a woman is about 1 in 9. What's the lifetime risk for breast cancer? Say again? Somewhere between 1 in 8 and 1 in 12, depending on where you are in the world, right? So 1 in 9 is somewhere in there. So for all the women in here, you know, if there are 100 of you, chances are 10 of you in this room will experience breast cancer at some point in your life. So it's pretty common, and that is an easy MCQ. Look at it. The stem is very, very thin. It's a sentence fragment. The options are very, very straightforward, and you can choose your answer based on what you know to be true, right? We know that for most women, there is no specific cause for their breast cancer. Most of them are not genetic. Most of them are not related to any known risk factor, right? So B is not an option. We know that the prognosis is not worse for rich women because the prognosis is never worse for rich women, right? Because you know that the socioeconomic status, except for specific populations, in general, the socioeconomic status is one of the major determinants of a positive outcome in the management of any kind of disease, including cancer. So clearly, the more affluent you are, the more you have access to screening and newer, accurate therapies, and therefore you're going to have a better outcome. We know that the incidence of breast cancer in relative and absolute terms is increasing, not decreasing. And so it's very straightforward. Would you all agree? Well, except the persons who put B and D. Most of you at least would agree that the answer is obviously A. Let's go to another type of question, a moderately challenging question. What is your answer to this question? Any thoughts? Come no? Nobody not engaging with me? I don't understand. I thought this was a straightforward session. All right. Nobody wants to talk, but everybody said C. Okay. Anybody have any other thoughts? Okay. So, yeah. Right? So we know that all, with very, very few exceptions, as a general rule, most of them are all the breast cancers in male are going to be diagnosed at a late stage. A, because they never access screening services. In fact, there is no real screening protocol for breast cancer in men because of the prevalence is so small that it doesn't justify a screening protocol for male breast cancer. And we know that because of men and their health-seeking behavior, they will always justify what is going on as some kind of romantic bite that they got on the breast, which causing this lump to develop, right? Or insect bite, I don't know. So it is invariably the case that men present late and therefore at stage 3 or perhaps at stage 4 and therefore will be candidates for radiation therapy. There's not much breast So as soon as the cancer starts to develop, it starts infiltrating the muscle, right? We know obviously that, well, you could argue about the superiority of mastectomy versus breast conservation surgery. It's not particularly superior. We know it has challenges, and managed properly and in a properly selected patient, breast conservation surgery will have similar outcomes to mastectomy. We know you can't use chemotherapy in the first trimester of pregnancy, that's bonkers. We can use it in the second trimester, even in the third trimester. And we know that Paget's disease of the nipple is often associated with underlying intraparenchymal breast pathology. So a simple excision of the skin and so on would not be adequate. It tends to be infiltrating widely. So it's fairly straightforward. You know, once you have some knowledge of the subject matter, you should be able to come to a conclusion of C. What about this one?
Doc, before we move on, quick question between radiotherapy and chemotherapy. Not really sure when you choose one over the other.
For what?
But in the treatment of cancers, chemotherapy versus radiation, like when do you choose one over the other?
All right, we're going to get into it. So once you're treating breast cancer, we're talking about breast cancer, that's why we want to restrict our discussion, right?
Yeah.
You start out from a default position that everything is on the table. Surgery, radiation therapy, chemotherapy, hormonal therapy, and the rest of the targeted therapies, right? And then you have to tailor the particular approach, treatment approach and algorithm to the individual patient that is with you in front of you. All patients will benefit from all of the therapies, right? So what you have to do is do a risk-benefit analysis, okay? So if you see a patient is stage 1 disease, for example, yeah, actually chemotherapy will reduce her risk of local and systemic recurrence, but you have to balance that with, okay, is this patient 93? Does she have a Bloom-Richardson 1 or 3 grade disease, et cetera, et cetera, et cetera. You have to look at the individual patient and make decisions for that patient. So it's hard for me to tell you as a general rule, chemotherapy is better than radiation or radiation better than chemotherapy. That doesn't really apply. You have to look at the patient, evaluate the various permutations in that particular patient and come to the best decision, which is why we have MDT and individualized patient management. But we'll get into that a little bit later. We'll get into some of the specifics.
Okay, Doc.
All right. Where was I now? We're about to look at a slightly more challenging example of a multiple choice question. Who wants to take that one?
But Doc, I'm gonna hazard a guess and say C.
Okay. Anybody else have any other thoughts? Come again? Anybody else? Everybody thinks that C is the right answer. Why isn't this question challenging for you? Give me 1 second. You will let me call you back, please. Yeah. Why isn't this question challenging for you? It's not particularly challenging. You can look at the answer, you can know it's the right answer immediately. So even though it has a lot of distractors in there, even though you have a lot of distractors, it's not particularly distracting because you can read the question and know almost immediately what it is that you're talking about.
I'll go after this. Yeah.
So even though you don't know much about radiation therapy and conservation therapy and node and so on, and the difference between AI and, or you may or may not know, you may not even know about trastuzumab and so on in terms of the targeted therapies, but you know that chemotherapy in combination, whatever their combination is going to improve survival in selected patients with early breast cancer, right? So sometimes, even though the question has a lot of distractors, like it's challenging, if you read the question properly, the answer is usually clear for you to see. It should feel like the right answer without even knowing a lot more of the information that is out there. So don't become too panicky. Sometimes I'll put some strange kind of distractors in there, but the answer should shine through all of that fluff. Now, so those are some theoretical questions that I pulled from my brain and other parts of the internet, right? Let's get real. This is a MBBS examination question from, I think, 2022. What's different about this question? There's a fat stem and slim options. The challenge here is that you have to get through all of that. You have to wade through all of that information to get to the options. What do you think the answer to this one is?
I would say margin status, so.
Anybody disagrees? So everybody agrees it's a margin. Indeed. So once you read the question, it becomes obvious. So a lot of things are in there, a lot of distraction, and the issue is in this particular kind of question is more the distraction. It's just giving you, it's just a bit of an annoyance because you have to get through all of that to get to read. Which of the following is not likely to be a feature for it? You know that you can't get marginal status on core biopsy, right? So you haven't assessed all of the margins in a core biopsy. There's not even an attempt to assess margins in a core biopsy. And therefore, you can't get marginal status from a core biopsy. So with all of that fluff, you can see the answer shine right through the back of the question. What about this one? Again, a fattish stem and requires you to have some kind of clinical exposure. What do you think about that one? Any thoughts?
So I believe that the treatment for phylloides tumor is wide local excision, so I'd go with D. So D or E. Yeah, one of those.
The challenge is that you only have one choice.
Yeah, that does tend to be the challenge with these.
Come again?
That does tend to be the challenge in multiple choice.
It does tend to be a challenge, and oftentimes you can whittle out a lot of the options, and you're down to two, and then you have to figure out what the hell do I do now with these two? Do I flip a coin? You know, what do I do? So let's look at the question. So most of you think that E is the appropriate option, right? But what is a lumpectomy?
As I understand, the lumpectomy is another way of saying breast conserving surgery, for example, in the case of a fibroadenoma. That's what I would start.
No,
Right.
it's just removal of the lump.
Mm-hmm. So would you remove just a lump in a phyllodes tumor?
No.
No, you
I
wouldn't.
think you might need the margin.
You need a excision.
Indeed, because you don't know if this is a malignant phyllodes tumor, and therefore, unlike where you have a fibroadenoma, which you think is a fibroadenoma or know is a fibroadenoma, you can cut right down onto the lump, onto the pseudocapsule, which is basically the pseudocapsule is made up of compressed breast tissue that has become atrophied as a result of the expanding mass. So you have this pseudocapsule, which you can cut right down onto and basically shell out, if you will, to use a term from your generation. Oh no, that's shell down. Oh, shell out, yes. This mass right on the capsule of the fibroadenoma itself. But that's not something you would do for a phyllodes tumor. You have to take that out because you don't know if you're going to get a positive margin. So you take it out with what looks to be a penumbra of normal breast tissue, just to make sure that you're getting all of the margins of this mass out. So this kind of thing now, coming to you, Cesar, this kind of thing now would require that you were around, right? Because if you weren't around, you would know what the difference is between a wide local excision and a lumpectomy, because those are two entirely different approaches to the management of lumps in the breast. Yes, you had a question.
Hi, good morning. I was just wondering if there's a specific centimeter cutoff for wide local excision. I have learned it as 2 centimeters.
Sure, and that's perfectly reasonable. So what we try to do is go for 2 centimeters, because we know that in reality, in taking out the lump, you can't really measure clearly what the difference is between 2 and 1 and 2.5 centimeters. That's not something you can discern with a great degree of accuracy in the course of surgery, right? So we usually go for 2 centimeters and get a normal penumbra of breast tissue. But if you get 1, that's why we say at least, that is also acceptable. As a matter of fact, any negative margin is acceptable. So whereas you go for 2 intraoperatively, if you get at least 1, that is also still acceptable. All right. So did that give you a proper flavor of what is to come?
Yes,
Yeah, and you can properly appreciate the difference between how MCQs, which you might read about in your books as you're preparing or from the internet, are structured versus how the MBBS MCQs are structured. It's a whole other thing. So you have to read it in your preparation with these kinds of methodologies in mind. That's because this is how we ask questions in MBBS. All right, so let's get back on topic. So we know that the breast cancer is pretty common, about 1 million women. A lot of persons dying every year, a lot of persons being diagnosed every year, 1 in 8 to 1 in 12 lifetime risk. And we know that the incidence is continuing to increase. In Jamaica, the last time we looked at this statistic, it was about 43 per 100,000. I know it's higher in places like Trinidad. I think it's about 78, and even higher in Barbados. In the US, it's about 110 per 100,000. Right, so it's growing, and it's growing relative to other kinds of cancers. So, if you look at a few years gone by, cervical cancer was the most popular, if you will, kind of cancer, the most prevalent type of cancer. But what has happened is that breast cancer has gone up in absolute terms, and cervical cancer has come down because of things like HIV. And you know why HIV reduced cervical cancer, right?
Cervical cancer is one of the AIDS-defining illnesses, and AIDS is a dying trend because we have the new antiretroviral drugs that are widely accessible.
I'm not sure if you answer my question directly. Why did AIDS lead to a reduction in cervical cancer?
Doc, is it because people started practicing better sexual habits?
Well, I would say different. I don't want to be judgmental and subjective about what is better and what is worse, but it's certainly different. Our sexual hygiene has changed. Condom use has become more widespread, and unlike in the 60s where it was a good time for all, we are a little bit more discerning, except students on campus, of course. But generally, populations are more discerning. And then, of course, you have things like Gardasil, HPV vaccine, which has been rolled out widely, and all of that has led to a reduction in cervical cancer, and therefore the ascendance of breast cancer to be #1. I don't need to dwell on the anatomy of the breast. Surely you know the various parts. So when we speak about suspensory ligaments of Astley-Cooper and pectoralis fascia and so on, it will be clear to you what we're talking about without having to break it down. when we speak about the lobules and the ducts, the lactiferous duct, the lactiferous sinus, and so on, it should also be clear to you what we're talking about. So we don't want to get into, we don't want to go too basic. All right, what is the purpose of having a breast? What is the function of the breast? Well, obviously, well, maybe some of you find this picture provocative. It's not me, it's United Colors of Benetton. So what does this picture evoke for you?
One of the functions is that it provides milk for the baby.
Yes, it does. That is the purpose of the breast, right? It does. Jacket, really, guys? Come on now.
You see the chest.
Reverse paternity fraud. I don't know. You didn't realize, oh, that's wonderful. You're a man of the world, Matthew. Anyhow, so the breast its primary function is to breastfeed. Some say, of course, not every woman has children, so that obviously it must have other uses as well. So this is a provocative picture for most persons. It evokes a memory of wet nursing, but we're too young to appreciate that. Obviously, the breasts are more important than that. It's a part of your character and personality. Some people make their livelihood from it. Some people view it as a secondary sexual organ. Some people say it's a primary sexual organ. And so obviously we can't just lop off breasts. If it were that breasts were only for breastfeeding, the woman would just get to the end of her reproductive career at age 40 or whatever, would just go ahead and say, okay, fine, you're 40 years old, it's time to cut off your breast now. But we don't do that, do we? Because the primary function or the only function is not to breastfeed. So it's important that we retain that perspective as we go through managing persons and their breasts. So what is breast cancer? It is simply cancer that starts with tissue of the breast, a very gross definition. And we know that there are different types, referring to it as a morphologic subtypes, which is a reasonably old concept. We can get into a little bit more about some of the newer concepts. So in the old morphological definition, we talk about the ductal cancer, where the thinking was and perhaps is that this is cancer that starts out into the ducts, or lobular, starting out into the lobules. And then, of course, you have the invasive subtypes of ductal, and in situ subtype of ductal, and invasive subtype of lobular, in situ subtype. As it turns out, this definition may not be so accurate, because sometimes breast cancer, the pathologist will identify it just based on what it looks like, as opposed to what the tissue of origin is. And so it might be difficult to say, based on the appearance, where it actually started out its life. So it's not really blunt concept. We know about the effect of hormones and cancer. We know that hormones cause cancers to grow. So whenever you have a cancer that is estrogen positive, it reacts to estrogen. There are receptors on the cancer that will grow in response to exposure to estrogen. All right? Likewise, progesterone. We also would know in the current dispensation about certain genes that tend to increase cancer growth, like the HER2 gene. And we know that HER2 positive cancers are, in general, more aggressive, right? So cancers that have the HER2 gene are more aggressive. However, the patients, if they have enough money, tend to do a little bit better when they have HER2 positivity, because if they can afford the Herceptin, then there's an additional avenue that they have to be able to block that particular cancer, and therefore they tend to do better. Now, you would have heard about BRCA1 and BRCA2 gene that were discovered in the 1990s, mid-1990s. But nowadays, we're talking about other type of subclassification, like your luminal breast cancers. And we know the luminal cancers are typically the ones that have ER and PR positive, HER2 negative. and a low proliferation index. The proliferation index, or Ki-67 here, is just an evaluation, a pathological evaluation of how fast the cells, the nuclear material is turning over within that cell. We call it a proliferative index, and Ki-67 is one of the proliferative indices. All right, but both the HER2, luminal A and luminal B cancers tend to do reasonably well, even though they have different profiles as far as their genetic profile. But as you go down this list, the cancers become more and more bizarre and unlike the breast tissue from which it derived, and therefore tend to be more and more difficult to treat, and therefore worse and worse outcomes in the patients who are affected by it. So you can talk about, whereas this might be a little bit beyond the scope of MBBS, it may come up for some of you who are better students. I remember in the year 3 exam, one of the students who ended up being asked about luminal subclassification of breast cancer. So it wouldn't be far-fetched, even though you haven't necessarily studied in your MBBS book, for you to be asked about proliferative index and Ki-67. So at least having a concept of it, knowing that it's good when it's low, proliferative index, and bad when it's high, is going to be useful. All right, so we know about the ER, PR, HER2, and then we get into some of the other genes, EGFR and Ki-67 and so on, right? So knowing about those is useful. Now, a genetic subclassification utilizing various tools like your MammaPrint and Oncotype data and so on, this is not required for MBBS discussion. So if you want to have a discussion about that, we can spend some time off-site discussing that, but I wouldn't encourage you to be delving too deep into it. It's very unlikely that it's going to come up in your exam. Perhaps if you're an exceptional student, it may come up in your ask, but it's not on the syllabus for MBBS. Because we have a particular issue in the Caribbean with BRCA, this may come up in some detail, right? We know that ordinarily the breast cancer gene is a small percentage of the population in an average first world population, the US population, and about 4% of breast cancer cases. You would know about this population of Jews, Ashkenazi Jews, just because they have been isolated and had limited relations outside of their community. They had an opportunity to concentrate a lot of genes and a lot of adverse genes, as it turns out. And so unlike the US population, where BRCA is about 0.1% penetration, in the Jews it's about 1%, so 10 times as much in this particular population. But interestingly, we have had some local studies that have not been rebuffed that spoke to extremely high genetic cancers in Jamaica and especially in Bahamas, where unlike the 4% in the US, it's 23% of BRCA1 and 23% in Bahamian breast cancers, which is an exceptionally high number. And so because there are some unique qualities, if you will, of the local breast cancer scene with respect to BRCA, it might be useful to be able to speak at least to the fact that it's common locally. Now, we know that the BRCA genes are typically associated with the ER/PR negative cancers, so non-luminal breast cancers, and as I would have told you before, the non-luminal cancers tend to do worse than the luminal A's and the luminal B's. We know that once you have had BRCA 1 or 2, your lifetime risk is pretty high, somewhere about between 50 and 70%, and therefore prophylactically attacking the problem even before the development of breast cancer seems to be a rational approach to managing the issue. Of course, it's also perfectly rational to say, well, my lifetime is only 70%. It means that I have a 30% chance of not getting breast cancer in my lifetime. And therefore, aggressive surveillance is also a reasonable approach to the management of this particular kind of breast cancer. So we would do imaging every 6 months. We stagger the MRI of the breast and mammogram to make sure that the woman is being evaluated at least every 6 months with some kind of imaging modality to come to the diagnosis. Many of you who are reading outside of your textbook would know about the Angelina effect, which is where she had BRCA, I think it was 1, and did prophylactic bilateral mastectomy, and therefore got her breast back up into her shoulders, where where she wanted them to be. So you can, if you're approaching prophylactic mastectomy, be able to have all of the reconstructive options at your disposal. That's the point, right? So it's perfectly rational and became very popularized because of the Angelina effect. But not to be ignored, though, is the other genes that also encode for high risk of development of breast cancer, like your P10 gene, high in the Jamaican population, P53, tumor suppressor gene, and that is the kind of the final gatekeeper. So once that is abnormal or overexpressed, then underexpressed, then you're going to have a problem. CDH1. So the point is that knowing about BRCA is important, but there are other genes that also have a higher risk of the development of breast cancer. The particular names are not that particularly important, but just know that there are others, right? So you don't have to necessarily restrict your discussion to just those particular genes. All right, so we know genes can cause cancer. Are there other causes? We can divide those causes. There's not really a cause per se. Let's be clear. What we know is that there are risk factors for the development of breast cancer. Not that there is any specific cause, but there are some risk factors, some of which are unmodifiable and some of which are modifiable. Now, things like your gender imposes an unmodifiable risk. We know that only 1% of men get breast cancer as opposed to the 99 women who get breast cancer. Even if you, I guess you can identify as a woman, but it doesn't change your risk necessarily. Age, breast cancer is a disease of women in their 50s and older. Obviously, it's getting younger and younger and younger, but it's still a disease primarily women in their 50s and older. What about race? What do you think about race and cancer risk? Does race increase your cancer risk, or which races are of increased risk of cancer?
Well, they
I know
say blacks, but it might be the reduced so okay, so some say that it's black people because they have reduced thing to screening.
I believe it's more common in the white population, but blacks tend to have more aggressive cancers like your triple negatives.
Okay. Those are interesting perspectives. So what we know is that it's not any more common in black people. It's actually more common in whites. But black people tend to die more from breast cancer. Part of the issue, yes, is access to screening services, or even if it's accessible, it's not acceptable in a lot of the population. So the women don't get screened. And therefore, if you look at, say, Jamaica, we diagnose most of our cancers, 2/3 of them at stage 3. At stage 3, you're talking about palliative intent as opposed to curative intent for stage 1 and stage 2. So in terms of the treatment intent. So yes, they die from it more as black people, but they get it more in white people. The issue of the aggression is a controversial one. And it seems to be that the more relevant issue is the access to the most optimal treatment. Because even in the same societies, say the US, even in persons of similar socioeconomic status, black people tend to do worse because of not appropriate exposure to the best available treatment. What about radiation exposure? You do have some people who have had radiation exposure, perhaps for breast cancer in one breast, and therefore it increases your risk of cancer in the contralateral breast. That is true. Or perhaps they were exposed with mantle radiation for a thymoma or, I don't know, other forms of radiation that then increase your risk of breast cancer. If you've had breast cancer, then your risk of breast cancer increases, right? So if you have had cancer before, I guess because of your genetic milieu or your environmental exposure, you know that you're going to have a 1 to 2% chance per year of recurrent cancer. And then family history imposes as much as a 30% risk. Your menstrual cycle here is meant to refer to when you started your menstrual cycles and when you end. So as you go through to your menarche, your breast tissue starts to become exposed to more estrogen. As explained to you before, estrogen is a putative risk factor for the development of cancer. So the more exposure you have had, the greater your risk. So if you started your menstrual cycles earlier and finish them later, let's say you start at 9 and finish at 6, 57 or something strange, then your risk is going to increase over that period of time. Now, so that is unmodifiable because you don't decide when your cycle start or stop in general. But the modifiable risk factors include things like your reproduction, your reproductive career. So if you would have had children earlier and more often, so before 35 and then more often, what this does is it applies brakes to the continuous attack, if you will, of estrogen on the breast tissue, right? Because as you go through the pregnancy cycles, your hormonal surges will change and estrogen levels will fall, and that provides a protective effect. Likewise, breastfeeding, protective effect. Now, things like alcohol and tobacco will increase your risk for everything, and breast cancer is no different. So hormone replacement therapy is one of those things that if you've taken a hormone replacement therapy after your menopause, when else would you take it, right? Then that exposure continues to expose the breast tissue to estrogen and therefore increases your risk by as much as 30%. The business of obesity is somewhat maybe controversial. What is uncontroversial is that obesity reduces your diagnosis because, as you know, all women have the same breast size, right? In terms of the breast volume. The volume of breast tissue is basically the same in most women. And what makes the difference is fat, how it is the volume of fat and how it is interlaced within the breast tissue, is glandular tissue, is what makes the difference. So in a size A cup breast, finding a 2 centimeter lump is fairly straightforward. It's going to be obvious. Whereas in a size H breast, it is virtually impossible to find a 2 centimeter lump. So the lump tend to get larger and therefore it become diagnosed later in life. There's also a thought that if you're obese, you get more peripheral production of estrogen from your fat cells and how the fat cells work with your steroids produce estrogen. So excess estrogen there could also be a risk factor, but it's more controversial. But certainly the late diagnosis is not controversial, at least. And we spoke about the radiation risk before as well. But there are also some what we call histological risk factors. Yes, go ahead.
Does it even have an effect of spread in terms of they have more breast fat or adipose tissue, you tend to have less spread as opposed to persons who have less size?
Come again. Pose the question again.
Does the number of fat tissue that is present in the breast reduces the spread as opposed to persons who have a smaller degree?
I don't think so. If you're talking about contiguous spread into the muscle, right? Then sure. Just like for the men, once you have a 2 centimeter lump, you're already invading into the pectoralis fascia and into muscle, right? Because there's just no breasts available. So with a female patient, once you have a certain amount of breast, that doesn't really apply. So unless you have a very, very small amount of breast tissue, that doesn't really apply. Because the spread in the case of breast cancer is not typically contiguous spread. It's typically lymphatic and then later on hematogenous spread. And as the cancer gets larger, we know that size is associated with greater access to the lymphatics and greater access to the hematogenous, to the blood vessels, right? So you get more lymphovascular invasion in larger tumors. So I would say the more obese patients tend to have a later onset, later diagnosis because the mass is hidden, and therefore the more time it remains hidden and the larger it gets, the more it has time to access the lymphatics and the blood vessels to become manifest as metastatic disease. All right.
Understood that.
Sure. So certain histological risk factors, talking about proliferative breast disease, especially when it's associated with the atypia and a strong family history. Your atypical ductal hyperplasia, atypical lobular hyperplasia, and so on, the lobular carcinoma in situ. So although these are not breast cancer, none of these are breast cancer. We know that once you have any of these conditions, you're subject to an increased statistical risk of the development of breast cancer in the future. So for example, if you have non-proliferative breast disease, your relative risk is 1. What does that mean? It means that you're no more likely to get breast cancer than the rest of the base population. Whereas if you get into the proliferative breast disease now, you're going 30 to 90% greater. And if you add atypical cells on your proliferative breast disease, then you're going to 370, 400% more. If you add a strong family history, it's 9 times as likely your risk of breast cancer development. And if you get into lobular carcinoma in situ and so on, it's about 7 times the risk, right? So understanding this concept of relative risk is particularly useful in assessing your patient's risk for the development of breast cancer. All right, and we're going to show you how to do that in a second. In terms of other things that your patient may present to you as the reason for their breast cancer, including mobile phones, that's not on. Even if you store your phone in your breast, no link demonstrated 5G, no link demonstrated meat. Actually, no link demonstrated. So meat has been associated with colon cancer, and especially high volume meat consumption. Your Brazilian levels of meat, and then also preserved meats, so nice pastrami's and so on. Those have been associated with colon cancer development risk, right? But not proven in breast cancer. How about obia? Leave it alone. Now, I want to introduce you to this concept of a model for breast cancer, risk model. And the most common one that you hear people talk about is the Gale model. I wouldn't want you to attempt to hold all of the variables of any of the models in your head, especially at this time. You have more important and bigger fish to fry. What you have to know is that there are these models that are, and there some of them are unique to particular subset of population. So for example, BRCA Pro model is used in persons with BRCA1 or 2, right? But the Gale model is kind of a more general risk model. And what this will allow you to do is to plug in the various variables, age, sex, race, minority, etc., into this model, and a computer program will spit out a number at you. And the number it will spit out is a number called relative risk. So similar to all these histologic risk types are giving you an increased risk, the Gale model will give you a relative risk calculation. And based on the relative risk, you will know, okay, this particular patient is deserving of more aggressive type of screening. So they wouldn't be screened in the way we screen the average risk population. We'll have to find a different way, a more aggressive way of screening them, etc. This patient is to be considered for prophylactic mastectomy based on all of based on the relative risk calculations, a discussion to have with that particular patient, right? So knowing the concept of these risk models allow you to just go on your smartphone, get the model up, punch in the variables, get your relative risk calculation, and then what you have to know is, what do I do with the number that I get out of the risk calculator? The relative risk. That's all you have to know. All right. So all of that was just preamble. You guys want to stretch, or you're good to go?
Good to
go.
All right, good to go. Let's go. right? Because I want you to get it at the end, you know? I want you to get it. All right, so how do you diagnose breast cancer? It's the same way that you have always diagnosed breast cancer. You take a history, you do an examination, and you decide what additional tests you need to do based on the history and examination. So in terms of the history, unfortunately, it's not good in the case of breast cancer because there are really no early signs or early symptoms of breast cancer. Maybe if you're lucky enough, you might find a small lump or see some other changes in breast contour or some nipple discharge. But typically, the presence of early signs and symptoms is really, really not there. And when you start getting signs and symptoms, it usually means that the horse has bolted. You know, Elvis has left the building, the water has gone over the weir, etc. And the other one, it's late, right? So when you start getting pain, bone pain, you're talking about metastatic disease, or breast pain, you're talking about skin infiltration or nerve infiltration or ulceration like we showed in the picture, it's late. When you start getting arm swelling, it's late. When you start getting weight loss that's speaking to metastatic disease, it's late. So what is the point? The point is that you should aim not to diagnose breast cancer based off signs and symptoms. So know what the possible signs and symptoms are, but that is not where we want to leave it. So having done your history, having done your examination, we can then subject the patient to a raft of various types of investigative tools. Mammography, ultrasound, MRI, and CT scan are the usual ones that you know about. And we can just go through and talk to you about what is relevant in particular situations. And then, of course, definitively, we can make a diagnosis of the cancer by certain types of biopsy, which we'll jump into in a little while. And we'll talk a little bit about the sentinel lymph node biopsy as well. Now, mammography can detect breast cancer early and therefore reduce mortality.
When time you just join the class.
Yes, go ahead. What was that?
How about this? Never knows the class like one.
I'm sorry, repeat your question. Was that a question? Okay.
I don't think so, Doc. You can proceed.
Okay, great. All right. So the risk reduction in terms of dying from breast cancer is actually quite modest with mammography. It's a horrible tool, isn't it? It reduces your chance of dying by about 15% in early patients, right? But as you get older, in your 60s and so on, something happens. Your breast tissue tends to become more devoid of glandular elements. So those denser elements in the breast are gone and it's replaced mostly with fat. And then when you have fat there now, mammogram can really see into that breast quite nicely. And therefore your risk reduction of cancer gets more impressive as you get older. But of course, you're dying from other things already anyway, but that's another matter. But in terms of how it is useful, we know that we don't ordinarily, and this is depending on which population you're in, use it in patients who are younger than 50. In Trinidad, in Barbados, the US, we still use it in 40 in Jamaica. 40 we start at 40 as opposed to 50 in other places in the world. Because we know that the risk benefit may be more advantageous to starting earlier in the local population because we are bad at it in terms of our health-seeking behavior and tend to diagnose cancer later. In other places in the world, they have to do a calculated assessment to see if it makes sense from a financial perspective to start at age 40 because the pickup rate is so low. All right, and we know that you may be presented with images in the exam to evaluate mammographic images, and you have to appreciate the difference between a transverse or medial lateral compression and a craniocaudal compression. So medial lateral oblique would be kind of what this image is demonstrating, as opposed to compressing the breast vertically, a craniocaudal compression, and therefore knowing how to interpret the two views becoming important. So I saw this on the door of the old mammography suite. I'm not sure if it was useful, but it was actually on the door of his mammography. Can you believe that?
Doc.
Yes.
So for the purpose of OSCE, when you all ask us, when do you switch over from, if you have to do, say, a triple assessment for a patient, switch over from ultrasound to mammography, what age do you all want to hear? Because I know that's 35.
Right. So we know that. All right. Let's talk about that. So we know that less than age 35, the breast is so dense that mammography is not particularly useful. Right. So ultrasound is used in that particular age group. Here's the challenge. There's actually no protocol for routinely evaluating a 35-year-old breast. See if you follow me. There's no screening protocol for 35-year-old women. And so there's no protocol for that says below age 35, we need to evaluate it. So clearly it will be in a patient who has some kind of symptom. And you have to evaluate the particular individual patient and say, okay, fine, based on this symptom, this tool is going to give me the answer better. Now, what we do know is that even in older patients, they are now combining mammograms with ultrasound. So a mammosonogram is giving us more information than a regular mammogram. So even though we recognize that mammography is better as you get older, we know that the pickup rate of pathology less than 50 is not particularly good. So as you go low below 50, ultrasound becomes increasingly more useful. But even in the older population, we still use ultrasound along with the mammogram to evaluate the patient. So you're entirely correct to be more straightforward in my response that under 35, we tend to use ultrasound as an investigative tool more because the breast is just so dense that it's hard to compress, it becomes very painful, and the pickup rate is not good because of the density.
Gotcha, Doc. Thanks.
Mm. All right. So you can be presented with mammographic images. And so you have to appreciate that what a normal mammographic image look like. So normally you get more density towards the nipple complex, and you see a nice normal breast tissue with all of the interlacing blood vessels and suspensory ligaments and so on. Right? So normal mammogram. What do you think about that one? Normal or abnormal?
No, I think it's normal, just older.
Come again?
Like
I didn't hear.
I think this is also a normal breast, but perhaps just an older one. So
You want the older woman? On which side?
the left side.
Meaning this one.
Oh, I guess the right.
So this is a normalish looking lymph node in the breast, in the axillary area, axillary tail, and really beautifully even distribution of fibers here, normal breast. This is also a normal breast, but it's a young patient. See that? So the breast is dense, and this is why mammograms are not particularly useful in young patients. By the way, you do have some, or even older patients who have dense breasts. And so your mammographic report will come back saying dense breasts. Therefore, the mammogram is totally not useful to evaluate this particular patient. You have to go with a different modality, right? But a younger patient is going to have denser breasts. What about this one? Problem? Normal or abnormal?
Looks like normal. Looks like some calcifications in the
You're getting some calcification in the duct, and you're getting some calcification in some very well-defined fibroid. So abnormal, but not cancer. You see? So you have to, what about this one? You see these big macrocalcifications looking like popcorn out in the breast, well-defined. again, not normal, but not cancer. What about that one?
This now is cancerous. We're seeing a irregularly shaped spiculated mass with some tethering of the nipple.
Indeed. You're seeing all of that here. So architectural distortion, retraction of the nipple. You can literally see the desmoplastic reaction in this particular case, right? Here, macrocalcification, increased density, architectural distortion. Again, cancer. So these are the kind of things you'll get in the exam if you're going to give you mammographic images, like obvious things, right? We're not going to give you anything very subtle. We're going to give you either a normal mammogram or cancer of the breast with obvious findings. So we're not trying to make you into a radiologist, but we know. All right. So again, to make the point that mammograms are reasonably sensitive, but not very specific. The challenge with mammograms is that they often result in further investigation. And the vast majority of patients who you investigate by biopsy and so on turn out to have a benign histology. Of course, by then the patient will be bankrupt and their nerves will be frazzled because they're thinking that they have breast cancer for the 2 or 3 months it takes you to complete your diagnostic workup. So there's this system that has been developed to try to reduce the amount of anxiety and unnecessary further imaging in patient and further tests in patient with abnormal mammogram. It's called a Barrett system, breast imaging and reporting data
Dr.
system.
Powell?
Yes, ma'am.
I just have one question. I'm still kind of confused on what's the difference between a diagnostic mammogram and a screening mammogram. Could you go over that, please?
Of course. So it's the same mammogram, right? It's the same tool that you're utilizing in getting the investigation done. The issue is when you apply it. So in a screening mammogram, you're obviously in a situation where the patient is not symptomatic. So you're either going to screen them based on some predefined target that they hit. So in Jamaica, they hit 40, they're qualified for screening. In Trinidad, they hit 50, they qualify for screening. As population screening, and you'll go through and screen the entire population of over 50 or over 40 patients. Or you're talking about opportunistic screening. The patient comes to your office for an infected great toe, but they are 53. Let me have a look at your breast. Let me write up a mammogram request for you. So the patient didn't come for that, but you took the opportunity to say, let us get screened because you are at risk, right? So that is how we would deploy the technology in situations where there is no symptomatology to report. In the investigative mammogram, it's the same thing, it's the same study, but you now have a patient who has a symptom or who has a sign, and you're looking for specific things on an investigative mammography. So for example, the patient may have a lump, and you might reasonably ask the question, in a patient with a lump, why not just proceed with biopsy and take off the breast or whatever? But there might be other lumps in the breast. There might be multicentric disease in that particular breast. There might be unrecognized disease in the contralateral breast. So we still go ahead and do this investigative mammography in patients who have symptoms, right? So there's no difference in the technology itself, but the difference is the focus and when you deploy it. Understand?
I get that part. I'm clear on that part. But so in terms of the views and the use of compression or magnification, how does that different? Because, I've been asked before, what's the difference between a screening and a diagnostic? But then I was asked, in terms of the views, how do I know one is screening and one is diagnostic?
Right. So the two standard views, so the two standard views are going to be your craniocaudal view and medial lateral oblique view, right? Now, suppose you see something else in one of your, in your routine CCR MLO views. You can do spot compression and further evaluation of an interesting area of the breast for greater clarity. So you can provide, but you would do that anyway. Even in your screening mammogram, if you see something abnormal, you call the patient back and say, okay, I want to look back at this particular area, right? In the investigative mammogram, you would probably do something else. You would probably do things like find the lesion. You could do things like put a marker in there, stereotactic marker in there, or something of the kind. So you could do more with a diagnostic mammogram that is meant to achieve a particular purpose. But ultimately, the technology is the same, and the initial, and you start out with the same standard views. It's just where you go with it afterwards. Are you going to put in wires based on your mammogram or mammosonogram? Are you going to put in radioactive seeds based on your mammosonogram? Are you going to put in clips based on your mammosonogram? It's diagnostic. So it's not really a very different technology.
Okay.
Some more?
Hi, good morning, Doc. Can you go over how we distinguish between the two views, please? I don't know if you could show us on the pictures previously.
All right, sure. I'll show you like so. So in your craniocaudal view, you basically have the two mammographic plates, the breast in the middle of it, and you're compressing the breast between the plates. So this will be the cranial, and this will be the caudal. So this will be a craniocaudal view, compressing the breast like that. Whereas in your medial lateral oblique view, there's a plate on top, plate below, and you're compressing, but it's not a horizontal compression, it's more oblique, extending up into the axilla. So the breast is being compressed like so. Right? Understand? So this is your craniocaudal, this is your medial lateral oblique view. And if you have those two views, you should be able to, in a three-dimensional sense, localize the tissue within the mass within the breast.
Okay, thank you.
All right, cool. All right, so your BI-RADS system is how we report the mammographic findings. And these days, we find that people are using BI-RADS to even report ultrasound or even to report MRI, but it's primarily a mammographic reporting system, right? The same interpretive value. And you can get any result from your BI-RADS report from 0 to 6. Most of you would know between 1 and 5, but you can get from 0 to 6. So in a 0, mammographic 0, it's an incomplete assessment, and it means you need additional imaging. So let me go back and show you an imaging and tell me what is a BI-RADS score for this image. What would the BI-RADS score for this one?
0.
0.
0, exactly. To be 0, because we need additional investigation in that particular patient, right? We can't use mammogram in that particular patient. Something else has to be done. Ultrasound, MRI, whatever. Something else. It's an incomplete assessment. So the BI-RADS of 1, it is just a normal mammogram. It's negative, nothing to see here. Come back next year or the following year, depending on where you are being screened for your routine screening. Whereas a BI-RADS of 2, it's a benign lump. So it's that lymph node there. It's that same fibroadenoma from last year. It's that same cyst from last year. But we would say that the usual caveats apply. And the caveats are usually like, well, you know, it could look normal and be abnormal. So you have to do clinical correlation with your physician who sent you for the mammogram to make sure that this normal or this benign lump is really benign, right? So when it gets a little bit more dicey now is where you get into the BI-RADS of 3 and 4, because in this particular case, with a probably benign one, you still harbor risk of malignancy at 2%, and therefore they want to tell you, okay, let's repeat this imaging in 3 months or in 6 months, or let's try something else to get better imaging. Whereas when you get to 4 now, all of the 4s need to be biopsied because you can't live with a risk of malignancy between 2 and 95%. So what we do in using the biorats to report is to reduce the number of patients who ultimately go to biopsy. So whereas before, when you had a benign lump, people would say, well, let's go ahead and stick a needle in that, right? Or even biorats 3, now we say, no, let us just deal with this, reserve the biopsy for the persons who are biorats 4 and above, and then take it from there. So you reduce the number of biopsy and therefore reduce the number of unnecessary biopsy in the patient population. All right. So a biorats of 5 is highly suggestive of cancer, and therefore, you have to treat accordingly. But a biorats of 6 is, you probably don't hear about this one. This is in situations where you have already biopsied the cancer, right? So you felt a lump or did an ultrasound, you biopsied the cancer, it came back confirming the cancer. And the question is, why would you bother to go ahead with a mammogram? And it is because you want to look at the rest of that breast for multicentric disease and to look at the contralateral breast for the presence of cancer that is subclinical on the other side as well. All right, so that's your biorats system. So you may that might come in your MCQ, that could come in your OSCE examination. Ultrasounds are useful, and they are used to distinguish between solid and cis primarily. And then, of course, in the younger breasts, in the younger, denser breasts, they are particularly useful where mammographic evaluation is going to fail. All right. Your MRI, yes, is used, but not in a general sense. Because part of the problem with MRI is that it overdiagnoses things. So anywhere there is some kind of abnormal water distribution in the breast, MRI will report as abnormal, therefore triggering other investigations, including biopsy, which turns out to be unnecessary. It overdiagnoses things.
Hello?
So we don't use it. Yes?
Mommy? Your
Okay.
mic is open.
Okay, so we don't use it in the average risk population. We use it in patients who have certain specific type of high risk, like your BRCA patients or other genetic risk factors associated with high risk of breast cancer. So, or a patient who you put in your risk calculator and it turns out with a relative risk calculation of greater than 2 or greater than 1.5 even. So it's not to be used in everybody, that's the point. It's used in particular situations in patients with a higher than typical risk of the development of breast cancer. So example, in the mammogram I showed you, the biorats 0, where the breasts are particularly dense, right? You would go ahead using a MRI in that particular patient. All right, biopsy. How do you confirm? So we've gone through the history, we've gone through the examination, we've gone through some of the radiological evaluation. Where do you go next? You want to do a biopsy. You want to confirm that there's cancer in the breast. And the options would be fine needle, where you just stick a needle at large as 21 gauge, about 6 or 7 passes through the lump, and you squirt out the cells onto a slide and you evaluate to see if they're abnormal cells. Now, remember, the fine needle does not reliably distinguish, in and of itself, doesn't reliably distinguish between invasive or in situ disease. So if you have a 1 centimeter lump or a 0.5 centimeter lump, you stick a needle in there and get back some cells, that doesn't tell you if it's invasive cancer or if it's ductal carcinoma in situ or lobular carcinoma in situ. It just tells you that the cells themselves are neoplastic. However, if you can clinically correlate, if you see a big massive ulceration coming through the nipple and you have a fine needle with a positive cancer cells, obviously it's invasive cancer, right? So you have to be able to stitch together the clinical information along with the fine needle to be able to come to a final conclusion as to what you're looking at. With a core needle though, which you will always get in your exam, we know we can get more information because you can now sample the mass to know if, when you look at it under the microscope, if the cancer is invading below the basement membrane. And once there's breach of the basement membrane and cells in the interstitial areas, we know that the cancer is invasive. So we can get that information from a core biopsy, which we can't easily get from a fine needle. In addition to that, we don't often do immunohistochemistry on fine needle samples. It can be done, but for your purposes, I would say no, right? So we can get a little bit more detail if we have time about the pros and cons or the possibility of getting the information from a fine needle. But for simplicity's sake, let's leave it alone. All we can get from a fine needle are cells, and the core can give us invasion. It can give us estrogen receptor positivity. It can give us HER2 new positivity. It can give us progesterone. So it can give us all that information. So we prefer cores to make a definitive diagnosis. In some very, very limited circumstances, we have to do incisional biopsy or an excisional biopsy. Yes, Matthew?
But I suppose you might be getting to it, but I wanted to know, given how many more advantages core has over to FNAC, under what circumstances would we recommend doing FNAC? Because I've been asked that question multiple times in the surgery clerkship, and I hear different answers from different consultants. Some say we never do FNAC because it's not helpful. Others say there are certain circumstances. I want to know if you have like a definitive answer.
Sure. All right. So I'm in the camp that says we never do FNAC. I never order them. I think they're a waste of time because they're so limited. Now, if you're in a space where your pathologist can give you receptors based on cellular analysis, then FNAC is useful, right? But in our local situation, we don't get reports of receptors based on FNAC. The only time I would recommend using an FNAC is when it is obvious cancer. And you just want to a pathological confirmation that it is cancer and not a radial scar or something strange. Then you would go for a fine needle, or you may go for a fine needle, and it can tell you, okay, well, this what you're looking at, it looks like cancer, and on fine needle it is cancer. Let's get started with the rest of your investigation, the rest of your treatment. That is when it will be useful. So take, for example, somebody with metastatic disease. And you want to know that it is cancer, so you can start your chemotherapy without delay. Then, yeah, you might want to consider a fine needle. But the core can also be done quite expeditiously. So I almost never order fine needle biopsy. If I have to choose an indication, it will be in circumstances where there's an urgent need to get a quick diagnosis in an obviously, clinically obvious breast cancer.
Okay, thanks, Doc.
All right, cool.
Excuse me,
All
Dr.
right.
Powell.
Yes,
Dr. Powell,
ma'am.
are you able to hear me properly?
Yeah, go ahead.
Okay, so if we're handling the core needle and we describe it, to explain the use, and then we go on to speak about the benefits.
Sorry, you sound very distant. Come back again.
If we're handling the core needle and we describe it and then we speak about the benefits in terms of histology and immunohistochemistry, what else do we need to speak about, or is that sufficient?
Yeah, that is quite efficient. You can speak about the fact that it can be done as a minimally invasive deployment, that it is greatest image guided as well as opposed to freehand. You can evaluate all kinds of situations, including cysts, complex cysts. You can target particular area. So you can go through the process of looking at some of the unique qualities of it. But most likely they're going to want you to compare it to a fine needle, and the usual difference between it and the fine needle is the receptor issue, and invasive versus in situ issue. Of course, it costs more, so that's a disadvantage. All right, so open biopsies are hardly ever done because we can almost always get more information without an open procedure from a core biopsy. In addition to that, once you have done an open biopsy, you know have a scar on the breast, which is going to limit your options as far as surgical treatment, because whichever option you choose will have to excise that scar for cosmetic and oncologic reasons as well. And therefore, it limits your options. The only time we do open biopsies when there's no other way of getting to the diagnosis, or perhaps when the surgeon wants some more money. But of course, we don't know any of those surgeons, so it's almost never done. And those are, well, we have gone through the various advantage and disadvantage, fine needle versus core. The other thing I would add here is hook wire localization versus iodine 125 seed localization. And what that basically is that when we find an abnormal lump in the breast, we can either stick a wire in there if it is a non-palpable lesion that we want to take out. We can stick a wire in there and the surgeon can be guided down based on where the wire is to know which part of the breast to take out when the lump is not palpable. Or we can put a radioactive pellet inside of the abnormal area, and this radioactive pellet is going to discharge radioactive material that can be picked up with a gamma camera. So intraoperatively, you can figure out where the lump is by where the radioactivity is coming from. The obvious advantage here is that you don't have to have a wire sticking out. And you can tag the patient for a longer period of time without the attendant risk of the wires moving or slipping in and out of the particular patient, as opposed to with a wire where you have to go straight from the mammographic suite or the ultrasound suite straight into the operating theater for fear that the wire may slip and lose its position or infection may come in. So we do both of these techniques here as well, but only in patients who have a non-palpable lesion that needs to be excised. All right, so we have diagnosed the cancer. And the next thing we want to do is to stage the cancer. Why? Because it tells us how to treat, and it allows us to tell the patient how long they're going to live or what they need to expect. Do you go for your will, or do you continue your life, business as usual? And there are many staging systems that we utilize. The Manchester staging is a very blunt tool, and I don't really recommend it to anybody, but for the most, well, let me put it this way. I know you have a lot of things holding that you have to hold in the back of your head coming up to this exam, right? If this is all I can hold in your head, at least it is something that allows you to be able to clinically look at a patient in an OSCE and say, this is stage 2 disease, or this is stage 3 disease. The other staging system, so although it's a horrible blunt tool, at least you should be able to keep this in the brain. The other tools are more complicated to keep in the brain. So the early TNM that speaks to the size of the lesion is useful in terms of a T stage and end stage, but it becomes more complex. There's more things to hold in the head. And I don't recommend holding the AJCC in the head, except for the most brilliant of students, because it's just impractical to deploy in a clinical situation. So whereas it's a good tool and it's accurate and it gives better prognostic information, it's hard to hold in the head for clinical purposes. And so just for your purposes, I'd recommend see if you can hold this one in the head. If not, hold the basic one, all right? But don't tell them I tell you to hold Manchester. All right. How do we stage? We can stage by examination, clinical evaluation, or we use X-ray, ultrasound, CT, bone scan, or sentinel lymph node. So we do surgical staging as well. And we can get to the position of knowing what the stage of disease based on deploying the best bit of this technology. Typically, we start with examination, and then we move to CT scan, chest, abdomen, and pelvis, and a nuclear bone scan. We could also use a CT PET and eliminate the nuclear bone scan. All right, cool. Yes, somebody had a question? Oh, okay. Yes, go ahead.
Okay, so I was asking, would you consider like the self-breast exam as a routine screening thing for the breast? Or would you say that's not a part of the routine that is accepted?
Okay. I was going to address it later on, but since you raised it now, I'm going to just address it right now. So breast self-examination is no good. All right. So breast self-examination has not been shown to change the outcome in the management of breast cancer. It does not reduce the late diagnosis of breast cancer. It does not reduce death from breast cancer in a general population. It is only useful in experts. So it's just kind of a waste of time. So it's only useful in family nurse practitioners that are skilled in breast examination and in doctors who are skilled in breast examination to examine themselves. But the average population, controlling for socioeconomic status and intelligence and so on, in the average population, it doesn't make a difference. So whereas I used to spend a lot of my time as a student or a young junior resident teaching women how to do breast self-examination, I now don't bother. That's a waste of time, unless you're a doctor or a nurse. And that's validated. So we still tell people, yeah, man, know your breast, etc. You know, spend time examining your breast before your period or after your period or something. But we know it's not gonna make a lot of difference. So to invest a lot of resources teaching it is a waste of resources. All right.
Okay, thank you.
Okay. All
Excuse
right.
me, Doc.
Yes, sir.
Could you repeat what you said about staging as it relates to like the radiological things that you'd employ? Did you say typically it would be a CT, CAP, and a bone scan?
Yes.
Okay, thank you.
Right. That's typical. There are some always exceptions to the rule. So for example, persons will say if you're stage 1 or T1, then it's too much of a big gun to deploy. Mind you, you can have T1 disease with metastatic mets, right? But statistically, it's unlikely. And then of course you have to have other things in case you have renal impairment. And you can't do a CT scan because of renal impairment. You have to go to an X-ray of the chest and ultrasound of the abdomen and pelvis, right? So, but the typical patient gets a CT cap and a bone scan for staging purposes, along with the physical examination. Now, we have to talk a little bit about sentinel lymph node biopsy because we do it. And this particular procedure, we inject we use two identifying markers. We use a vital blue dye, like isosolvent blue or methylene blue. So use a vital blue dye, and then we also use a technetium 99 labeled sulfur colloid. And we can do an injection at various points. So the technetium is injected pre-induction, and then the dye is injected intraoperatively in the patient. And then we massage in the case of the dye, into the lymphatics. We don't really massage the radioactive material in. And what it does do is the dye gets into the lymphatic system and ended up going up into the lymph nodes. It gets in the lymphatic channels and go into the lymph nodes. Now, what we know about the lymphatic drainage of the breast is that when you have breast cancer, as the theory goes, the cancer spreads in a very orderly fashion. It gets into the lymphatics and it spreads to a particular lymph node or group of lymph node, and that's called a sentinel node. And then it spreads from the sentinel node to the other nodes within the axilla. Right? So follow me. If you can find that node, you can tell what the status of the axilla is. You can say the axilla is positive for cancer. That's all the sentinel lymph node can tell you. It can't tell you how many nodes are positive, etc. It can just tell you, hey, the cancer has spread beyond the confines of the breast to the lymph nodes. Therefore, you have at least stage 2 disease. Therefore, this is a treatment for stage 2 disease. Right? It doesn't tell you anything else. 1 second. Give me 5 minutes, guys. I need to just take this call from the hospital. Take a break. 5 minutes. I'll be back with you to go over sentinel lymph node. What is going on? You get it, right? Hewitt, you have a question?
Hi, good afternoon. Yes, please. I had a question. It was from before though. When answering questions about breast screening, exactly which guidelines should we answer with? Because the USPST would say, start screening at 50, and ACOG, an American Cancer Society, would say start screening at 40. So when asked the question in the exam, whose reference are we expected to be answering this?
All right. So I think what you have to do is to appreciate what that 40 versus that 50 debate means. So whereas before almost universally the screening started at 40, there was a recognition that, the pickup rate is less as you are younger and increase as you get older. But the thinking was that at least get in there as early as possible day to try to reduce the occurrence of ovarian cancer. Now, whenever you start having a population-based screening system where you're offering screening to the population, the cost has to be borne in mind. And if you have to screen a population of between 40 and 50-year-old women and pick up just a few cancers, then it is just not worth it from a financial perspective. So in societies where the insurance companies compensate for mammographic screening, they have changed the age to 50. Some have even changed it to 52, because that is where we start picking up, where it starts making financial sense to offer screening to women on an age, population screening based on age, right? Now, in Jamaica, and I suspect in other parts of the Caribbean, we have a unique situation, we have a unique challenge. And the challenge is that we are diagnosing cancers too late. We're diagnosing cancers and therefore have to do palliative treatment rather than curative treatment. Or we're diagnosing them at stage 3 in 2/3 of cases. And so to recommend, without local evidence, a screening age of 50, we think would be counterproductive. Now, accordingly, therefore, even though we recognize that we might not be doing the right thing, the local, as in Kingston, as in Jamaica, screening age is 40 based on the Ministry of Health. However, if you go just to the south and to the east of us, to Trinidad, the screening age is 50. So that came up recently in an MCQ question, and we had to actually throw out the question onto the MCQ because there was a recognition that there's a difference in the teaching as to when the screening age should start. So you have to understand what is the philosophy that dictates what the age, what age should start, and understand what is appropriate in your particular jurisdiction. It is not the same.
Okay, thank you.
All right. Was there another question?
Yes, Doc. Hi. I just wanted to clarify something with the sentinel lymph node biopsy. So this is done intra-op, and this is only done if there are no palpable lymph nodes detected clinically.
Mm-hmm.
And the dissection is done if there are palpable lymph nodes detected clinically.
Mm-hmm. So I'm trying to get to the nub of your question.
No, I just wanted to clarify that in my head.
All right, cool. Let me go over it again, and then if you're not clear, repose the question.
Okay.
Clear?
Okay.
All right. So we're using a double tracer. We're using technetium 99 label sulfur color. We're using methylene blue, isolvent blue, whatever blue. Right? We do the technetium injection pre-operatively. We may even add the additional step of doing a lymphoscintigram pre-operatively, where we can tell where the lymph node is, if it's in the axillary, if it's in the substernal, internal mammary node, etc. But let's not even get that complicated. Let's just go with the basic. We do the pre-operative injection of the technetiums, and then we leave it alone to get into the lymphatics by itself. And then when the patient is off to sleep, we do injection of the blue dye into the breast itself. Now, we inject it at various points. We can inject it intradermally. It gets into the lymphatic.
Extremely high.
But if we inject it intradermally, it would end up with skin necrosis. So we don't tend to do it if we want to preserve the skin. But if we're going to sacrifice an area of skin, we can inject intradermally. If we're going to leave the skin in place, we inject it intraparenchymally, either subareolar or peritumorally. It doesn't seem to matter. And we massage it for 5 minutes to get it to force the dye into the lymphatics. Right? Now, back to the theory. The theory states that the node that the cancer is going to spread to first is called the sentinel node. And it is the same node that the dye is going to spread to first. So we can identify that node, know if it is positive, and therefore call the patient stage 2 or positive cancer in the node. We don't do anything else with that information. So depending on what you're reading, if you're reading the older textbook, the older text will tell you, and when I old, I mean like 10 years ago, right? Will tell you that if you have a positive sentinel lymph node, you are supposed to, you're supposed to diagnose that intraoperatively, right? So you do frozen section analysis, and then proceed to a full lymph node dissection. That's old information, right? It may even tell you that if you don't have intraoperative frozen section, you can analyze the node afterward and then come back and do a delayed axillary clearance. That's old information. We no longer do that, right? The only thing that the sentinel lymph node tells you, the positive sentinel lymph node tells you, is that it is positive, and therefore you have to treat with the axilla because it is positive. So your chemotherapeutic regime is going to change. Your radiation approach is going to change if you want to treat the axilla with radiation. We no longer do completion axillary dissection, irrespective of the sentinel biopsy nodal status. Therefore, we no longer need to do intraoperative frozen section for a sentinel lymph node. It gets more confusing because that is the information as of 10 years ago. But in what we have discovered now is that there might be a small subpopulation that would still benefit from the completion axillary dissection. I don't want to confuse you. If you want to be confused, talk to me afterwards, and we can confuse you about the NSABP Z11 trial. Right? Just for now, accept from an undergraduate perspective that we do sentinel lymph node to stage the axilla, but we don't do completion axillary dissection. Talk to me about the controversies if you want afterwards. Okay, so after that whole process of history examination and evaluation and biopsy, we're going to get to this slide. Yes.
Sorry, I have a quick question just to clarify my understanding of what you just finished speaking about. So essentially, when you do the sentinel node biopsy, you're saying that there's no need for, if it comes back positive, the only thing that it really changes is your options for chemoradiotherapy, because now you have to treat the axilla as well. That's what you're saying.
Correct. That is what I'm saying.
Okay, thank you.
Right. So whereas you might have read that you do a completion axillary dissection, no longer relevant.
Understood. Thank you.
All right, cool. Although there's a minority report on that, but we can talk about it later. All right. So this is not a real slide, okay? This is a mashup of regular hematoxylin eosine stain slide in the background, and I superimpose a genetic panel over it. Why did I do that? To confuse you? Yeah, kind of. But just to make the point that in the current dispensation, we can't just utilize the old pathological assessment, and genetic evaluation of the individual cancer is becoming the norm. So whereas before you used to talk about, invasive ductal cancer with a Bloom-Richardson score of 6 and so on. Now we want to know, is it P10 positive? What is the Ki67 on this? What is that? So we now start getting into the era of targeted and individualized medicine. And so by the time you get to start practicing in a few years from now, I meant a few days, of course, that is kind of the direction of travel that you're going to have to contend with. Targeted, individualized, specific diagnosis of breast cancer. That is Jones breast cancer, not Jean's breast cancer, So your breast cancer is going to be where it's going to be at. Of course, we're going to be left behind anyway, because it's very expensive to do targeted treatment. But anyway, let's not get into that. All right, so treatment. How you treat it? Well, the aim is to get rid of the cancer, prevent recurrence, and extend the person's life. If you're talking about local treatment, it's usually surgery or radiation. And then your systemic treatment would be your chemotherapeutic agents, your hormonal treatment, and then more recently, your immunological targeted treatment. So the option for surgery is either a wide local excision or a mastectomy. Okay? Those are the only options you have available. Now, wide local excision typically means removing the lump with a margin of normal tissue. 2 centimeters grossly intraoperatively, but at least 1 centimeter. Although any negative margin on histological analysis will be acceptable, because you can't really tell while you're in surgery. Once you're going to do wide local excision or partial mastectomy, it means that the patient must be subjected to radiation to treat the rest of the breast that remains behind. If you don't have access to, or the patient can't access timely breast irradiation, and by timely I mean within at least 6 months of having done the original surgery, then the patient cannot get wide local excision. Now, with that option, you have to find a way to decide, okay, that is the mastectomy. What am I going to do with the axilla? And the options here would be some kind of axillary dissection, level 2 usually, or sentinel lymph node biopsy. Or if I can't identify the sentinel lymph node because the blue dye didn't work and the technetium didn't work, I do a level 1 axillary dissection. All right, so standard would be level 2 or sentinel, or if sentinel fails, I do a level 1. Okay, so that's wide local. Now, the mastectomies will be also come in different flavors, right? So in a mastectomy, you're trying to remove all of the breast tissue. And I put all in brackets there because you never can remove all of the breast tissue. There's always going to be some amount of breast tissue in the skin flaps or on the muscle or in the axillary tail of Spence or somewhere around. That is the basis for local recurrence of breast cancer. And so about 5 to 10% of breast tissue is going to remain after a standard mastectomy. The modified radical mastectomy is supposedly the gold standard. Of course, the purists will tell you that that procedure is no longer done because of modified radical mastectomy, in its purest sense, required you to take out to divide the pectoralis minor and take level 3 nodes. Right? So what we have done is a modification of that modification. And we still call it an MRM, but it really isn't in its purest sense. What we really do is a simple mastectomy and a level 2 axillary dissection. That is what we now call a modified radical mastectomy, which was not its original definition, is the point I'm making. Now you can do that, or you can do a skin sparing mastectomy, meaning you can take the nipple and the areola and leave the rest of the skin behind, so leaving the entire envelope of the breast. Or we can leave the areola and take the nipple, or we can leave everything behind and just take out the breast tissue from behind all of that. So all of those are options for mastectomy. And all of those options are going to have to come with how to treat with the axilla, either by level 2 or some other dissection, sentinel node or level 1 if sentinel node fails, right? So in a way, you have to start thinking about the surgical procedure on the breast a little bit divorced from the one in the axilla, and then decide what combination of breast versus axilla work you're going to do to get to proper surgical extirpation of the cancer. So with your modified radical mastectomy, obviously it's not pretty, but and by MRM I mean simple with level 2 dissection, right? That's what we mean by modified radical mastectomy. But the wide local is not that pretty either, because oftentimes you're left with imbalance, with asymmetry. And as you know, beauty is symmetry, right? So there's a question as to, well, who gets a partial mastectomy? And I think the the best way to think about it is, well, what do you have left behind after the surgery? After you have done appropriate surgery, do you still have a legal breast behind that looks like a legal breast and functions like a legal breast? If it doesn't, maybe you should consider a mastectomy, right? So who gets it? Well, size doesn't really matter in an absolute sense, but in a relative sense. So if it's a 5 centimeter lump in a size A breast, then taking that out is a mastectomy. I will go back to the same size H breast again, 5 centimeter lump, nobody will even know. So it's a relative issue. It's the size of the mass relative to the overall volume of the breast. You must take out the breast lump with good margins, and then you have to see what you have left. If you had done a biopsy and the histologic grade was unfavorable, then that patient probably shouldn't get wide local excision, shouldn't get breast conservation, because they're going to have a higher chance of coming back. If you're younger, you have a higher chance of getting recurrent disease in the breast. Why? Because you're going to live longer, and therefore over the long course of your life, you're going to be more likely to get recurrence compared to an older person with the same with all the other variables the same. Again, just to reiterate the point, that if you don't have access to adjuvant radiation therapy to the rest of the breast, then it's not something you can offer your patient. And to reiterate the point that even in the breast conservation, you have to do something with the axilla, whatever it is that you're capable of or have the technology to do.
Sorry, doc. So in
Yes.
that case, a younger patient would not necessarily be a candidate for breast conservative management. You'd go and be the older patient because of the risk.
Okay. So here's what I would say in response to that. You have to evaluate everything about the situation. I'm saying that the patient, if the patient is younger and wants breast conservation, the patient needs to have all of the other boxes ticked and needs to appreciate that they have a higher than average risk of recurrence. Now, it doesn't matter. If they get recurrence, they can always do a bailout procedure. They can always go back and do a mastectomy later on. So some women may take the view that I want to do the breast conservation surgery. I understand the risk of recurrence is higher. I'm going to manage that risk. So I wouldn't say in an absolute sense, if you're young, you can't get it. I'm saying if you're young, you have to, and you're going to get it, you have to appreciate that the chance of recurrence is higher.
Got it, doc. Thank you.
So it's becoming harder and harder to dictate to well-read and educated patients what they should do. My approach is always, well, if it was my breast, here's how I would approach it because of A, B, C, right? And ultimately, you're going to guide the patient through a decision tree, and hopefully you bring them to the point where you want to bring them to, but the options are going to have to be there for the patient. So I don't recommend breast conservation surgery for young patients because I know that the recurrence risk is higher statistically. But if they insist and want it, I'll still do it if they understand the risk. Yeah? Okay.
Yes, doc.
All right, where was I now? Reconstruction. So we can reconstruct in various ways and at various times. So the usual reconstruction you may see are the non-surgical ones, just kind of improvised devices just to restore the breast volume to get back symmetry. Or you have formalized prosthesis that you can also employ. Of course, you can then do surgical implants, which will take the form of various things. So these are what I've seen used as as implants. Everything from balls to teddy bears and scarves and socks and stockings, right? Rags and handkerchief. The point is to get back the same volume on the other side. But if you have more money, you can go for the Rolls Royce of external prosthesis. And this is supposed to be flesh color. I don't know. You tell me. All right. And these will now have you can match to your shape and size. And the texture of it, the feel of the prosthesis, the silicone, is going to be similar to the regular tissue, as opposed to something that is just worn inside the bra. Or you can do an implantable prosthesis, where this is now below the skin or sometimes even below the muscle to restore the volume of the breast. And then now, having restored the volume, what often you realize is that there's a lot of ptosis. So this person had a mastectomy and then an implant, and look at the difference. The implanted breast now looks like the 19-year-old breast, whereas this one looks more like Janet Jackson, right? So you have a problem. And oftentimes you have to do something called a balancing procedure to get away from that. You have to adjust to a breast lift and a areolar reduction and so on to get back to a similar symmetry compared to the other side. So obviously this is a bit ugly now, but once this heals up and the nipple reconstruction is okay, then it looks pretty nice and you can do a tattooing to get back to the right color.
Doc, I have a quick question. We do this at UE or KPH or that's private?
Yeah, man, we do it everywhere. So we do reconstructions all wherever there's a plastic surgeon. There are plastic surgeons at UE, there are plastic surgeons at KPH, there are plastic surgeons at Cornwall Regional Hospital. So they all have the capability of doing it. Of course, there are other considerations. It takes a lot more operative time. So you have to balance, do I spend my entire operating list doing this complex reconstruction on a patient when I have 3 other patients with cancers? Or do I just take off the breast and send them on their way? So, but the technology is available in response to your question. And the expertise is available. Of course, we can do a tram flap or a VRAM flap or removing tissue around to restore the volume of the breast and even to restore the skin. And that is perfectly, that is done as well on a regular basis. Or look at this patient in particular. We can do it either delayed or we can do it immediately. In this particular case, this patient had a areola sparing mastectomy with sentinel lymph node biopsy. And the right breast was removed. It's a little bruise, as you can see. And then we took skin from the lower abdomen. What we didn't really need the skin, what we really need was the fat and the muscle, and swung it up below the skin all the way to lie inside of this area to restore her volume nicely, right? And of course, as a fortunate side effect, you get a flat belly as well, which we could all use. All right, so apart from reconstructing the patient, just something you have to bear in mind that you have to also find some time to do some kind of psychotherapy to reconstruct the family. And there are a lot of resources available to be able to do that. All right, I have a few more minutes. So just to speak a little bit about the prognosis. So prognosis is going to be dependent on your stage. And as you know, if you're early, and this is old figures, they're a little bit better now, but the earlier you're diagnosed is a main point, the greater your chance of beating cancer, right? If you're diagnosed as a stage 1 or stage 2 or stage 0, then you're attempting to cure the disease. Once you get into stage 3, you're playing defense and catch up, and you're probably not going to survive with whatever or you're less likely to survive whatever the therapy that you have at your disposal. So early diagnosis is the key here. All right, so preventing breast cancer. Can you prevent it? Not really. But what we can do is modify risk factors, those that can be modified. We have already identified those risk factors, so we can modify them. We spoke about the breast self-examination and the uselessness of it in the average risk population, but usefulness of it in a medical population. All right? So we don't spend a lot of time drilling down into it because it's not really that useful. All right. We spoke about the issue here of screening and the age to start and the difference in the various jurisdiction and the justification for it. I won't delve into it too much more. 1 second here. Office calling me. Yes, honey. Mm-hmm. Sorry. So there are some controversies that might come up in your discussion for persons who are who are better. So it won't come up in the pass fail viva, but it might come up in other types of viva, like using MRI for screening for breast cancer, using tamoxifen as a chemoprophylaxis against breast cancer, those kinds of things. Yeah. So these are the issues that might come up. Prophylactic mastectomy, genetic screening for breast cancer in the average risk population. These are controversial areas, emerging areas in breast cancer management that are interesting, but not necessary. All right, that's where we're going to leave it. Any questions?
Hi, yes, Dr. Val, I have a question.
Go ahead.
So at that, you said for the breast conservation therapy, if they can't get radiation within 6 months of the wide local excision, they're not a candidate, right?
Correct, because the recurrence rate without adjuvant radiation therapy is unacceptably high. And therefore, it wouldn't be reasonable to offer a patient that option if the patient cannot access radiation therapy.
Okay, and then my second question was regarding the issue with the size. So is it that I thought when there was a large tumor to breast ratio, that's a direct contraindication to breast conserving therapy?
Yes, we're not
The
saying
size
anything
doesn't
different.
matter. So that kind of had me confused.
Right, but I'm saying that absolute size is not the issue. Relative size is the issue. You understand? So I'm saying, so you can't say, for example, that a 5 centimeter lump is an impediment to breast conservation therapy. In an absolute sense, you have to say, okay, 5 centimeter as a function of what? In relation to what? If it's in relation to if it's a 5 centimeter lump in a tiny breast, then obviously breast conservation surgery is not useful, because that a wide local excision in that particular patient is a subcutaneous mastectomy. It's a simple mastectomy. That's the entire breast volume. Whereas in a very large breast, a 5 centimeter lump is immaterial, and breast conservation surgery will be perfectly useful. So it's the same size, but in different size breasts. So we're saying the same thing essentially. It's a relative size. That's what makes a difference.
Okay, it's clear. Thank you.
Mm-hmm.
Look.
Yes.
So a patient does a complete mastectomy, and was on chemotherapy, and then a few years passed, and then she said that the cancer has returned, but not only returned, it's now in the lungs or liver.
Right.
So what's the protocol in terms of like follow-up after the course of chemotherapy has ended?
So you say the patient had complete treatment and has recurrent, metastatic recurrence.
Yes.
Right. So if the patient has metastatic recurrence, you would have to then figure out if this is local metastatic recurrence or systemic metastatic recurrence. If the patient is systemic recurrence, then you have to treat the patient systemically, meaning second-line chemotherapy or other targeted therapies for the patient, because surgery wouldn't be useful in that case, nor would radiation.
Okay, doctor.
So, question. My question dates back to the management of a positive sentinel lymph node biopsy.
Yes.
Is it that you're saying that we no longer do completion auxiliary clearance? Because my understanding was, and I believe it was birthed out of that same Z11 trial, was that it was dependent on the number of nodes that you got back positive that determined whether or not you're going to go back for surgery or just, do auxiliary radiation.
No, it doesn't, because you don't do in a sentinel lymph node biopsy, a standard sentinel lymph node biopsy, right? You don't count the number of nodes. You don't take out a set number of nodes. You go and see which node is blue and which node is hot, and you take those nodes. So sometimes it's one node, sometimes it's 3 nodes. So you can't use a number of nodes to know if you're going to go back to an auxiliary, because it's not an auxiliary clearance. So the number of nodes obtained is not relevant, because it's not reliable, because you don't know how many nodes you're going to get. Now let me clarify. So, because it's always an area of controversy, because the state of play used to be that you used to go back and do a clearance for every positive sentinel node that you got, either immediately or delayed. I'm saying that that is no longer useful, because what the Z11 trial that you're referencing provided evidence of was that it didn't make any difference as far as the outcome to the patient. It didn't change the life expectancy of the patient. So whether or not you went back for a completion axillary dissection had no impact on life expectancy of the patient, right? Now, what it did have an impact on is the complication rate. So you go back for a completion axillary dissection and end up with lymphedema or nerve injury or vascular injury, but no impact on the patient outcome. So what's the point of doing it? No point. So as a trial was aborted in the middle of a trial. They aborted the trial and said, we have been doing foolishness. Let's just stop now before the trial is even finished. That's how Z11 went down. Now, later on, and the rest of you don't want to hear can cock your ears, because it's now getting a little bit, we're getting into the weeds now. Later on, what they did was to discover that, hey, wait a minute, this trial was aborted too soon. There may be a subset of patients who may benefit from completion axillary dissection. And so they actually restarted a part of Z11 or similar protocol trial to discover who these patients were that may benefit from completion axillary dissection. So you might read in your spirit time about failures of Z11, right? So this is what the Z11 trial didn't answer. So they restarted the trial. I think it's going to report soon. But what is emerging is that it turns out that patients who are perhaps younger with more aggressive histology and some other factors would perhaps benefit from a completion axillary dissection. So just watch this space. It's going to emerge who those patients are. And it is emerging who those patients are. But I'm saying the standard is still, as of right now, until that emergence, that you do not do completion axillary dissection routinely in patients post-positive axillary sentinel lymph node.
Okay, thank you, Doc. So you said it just changes the approach to the management of the axilla then?
Correct.
Chemo or radiation therapy?
Correct. It upstages the patient and therefore changes the management.
All right, understood. Thank you.
Unless you want to get into the controversy, but I would beg you, do not get into the controversy unless you are adequately prepared and can manage that controversial discussion about Z11 failures. Just say, you don't do completion. And that would be acceptable to all modern surgeons.
Excuse me, Dr. Paul.
Yes, ma'am.
In terms of the format of the OSCE, I know we have 8 stations, but is it like 1 ortho, 1 NS, and then the rest would be gen surge?
No. So we have 8 stations, and they are
I'm not hearing you, Doc. I'm not sure if it's just me.
No, still I'm not hearing him either.
Me either.
Recording stopped.
with
Recording in progress.
usually 4 stations without
Doc,
patients.
we lost you.
One station has orthopedic things, other stations have. So you'll have an anesthetic station, for example, which has anesthetic stuff and resuscitative stuff. You'll have a GI station, which
Sorry,
has.
Dr. Powell?
Yes.
I'm sorry. Unfortunately, you blanked out as soon as you said it's 8 stations, and then we didn't hear anything else until just now. So could you repeat kindly?
Of course. So I'm saying you have 8 stations, usually 4 with patients and 4 without patients. Right? So 4 with, 4 without. And the stations that are standard are usually a GI or GU station. So we deal with instruments and GI and GU stuff. We have an anesthetic station, anesthetic and resuscitation station. We have an orthopedic or trauma station, and we have a miscellaneous station. Those are the stations without patients, with inanimate objects, right? Any of those can have images associated with them. X-rays, CT, mammograms, whatever, ERCP images. So all of those 4 are usually associated with something. And then the other stations now would be patient stations. And the patient stations would have typical things that you see every day. Hernias, you must get a hernia. Breast lump, you must get a breast lump or some other breast other lump. You are going to get a vascular station of some sort, a venous, ulcer, diabetic foot, etc., etc., etc. So those are kind of the standard things you're going to get at your stations.
Okay, thank you.
Mm-hmm.
As it relates to the written paper, I know. So is it a case where we're only gonna get MCQs and we're not getting like AMQs and SAQs? I know some cases we tend to do that. So just wanted the clarification.
I'm actually not sure about that. I can get back to you on that point with the written paper. I know we have been doing MCQs only over the break, but what did your schedule say? They would have told you this before, eh? If it's MCQ alone or extended math.
No, Doc, we haven't gotten any updates. Only the schedule, but not really the breakdown of or the format of anything.
I'm gonna see if I can convince the relevant persons to just send you a little bit more information about the structure.
Thank you, Doc.
All right. So you say we don't want you to go in there blinded to what the structure is. That's not a part of the exam. You should know what to expect.
Excuse me, Doc, also including the days that each person's with different groups are going, because we know that there are 3 groups, but we're not sure who is going which days.
So yeah, that will come. That breakdown will definitely come. All right. All right, guys. Any other questions? So if you think of anything else, just send me a WhatsApp message or an email or something, and we can get into some more details. I would encourage you in your final review just to kind of look at what is essential information, so-called red knowledge. The white knowledge and the postgraduate diversions and controversies, you can take them on if you're capable. But if you know you're not capable, you have to know yourself by now. Just deal with the basic bread and butter issue and get through the exam. Right? You will not pass or fail on the basis of your knowledge of esoteric facts in some corner of some article. You will pass or fail if you don't know basic stuff.
One more question.
Dr. Paul?
Yes, ma'am.
So for medicine, we got a breakdown of the MCQ as well. So when you're asking them, can you also ask them that? So for medicine, they said X amount of psych, this amount of gen med. So could you ask that as well? Like how many questions for urology, how many questions for ortho, etc.
Is that useful to you?
Yes, no.
You're asking for the exam blueprint. I'm surprised they gave you that. I can ask.
Dr. Powell, when you were talking about that we don't do axillary lymph node dissection anymore, you're talking about a level 3 as opposed to a level 2. So we still do
let me clarify. So I'm saying that in the context of sentinel lymph node biopsy, we don't do a completion axillary dissection anymore post positive sentinel lymph node. Right? Clear?
Okay.
Obviously, we still do axillary dissection for standard axillary clearance, and the typical standard is a level 2 axillary clearance. So level 2 up to the axillary vein or just behind the pectoralis minor muscle. Level 2 is what we do. What we know is that if we go higher to get more nodes from level 3, then it doesn't make any difference to the patient outcome, but it makes a difference to the amount of injury, vascular and nerve injury that you get. So we don't go beyond level 2 as a standard. Okay? Very, very rarely we do a level 1, and that is only in circumstances where we're trying to do a sentinel node and we fail, we can't identify the node. So go to level 1 because you know that the sentinel node is usually within level 1. Follow me? Now,
Yes, sir.
so I could say we almost never do, or I could say we never do level 3 axillary dissection. But of course, you know, there are always minority reports. There are always strange and weird circumstances that would force you to do a level 3 axillary dissection. Like if you get a level 3 recurrence, right? That is not BMI. So, but I don't want you to get into that. For your purposes, the standard axillary dissection is a level 2. Or a sentinel. And only in failed sentinel, you do a level 1. Let's just keep it simple.
Okay, so you're saying that if the patient is clinically has clinically positive axillary lymph nodes, we do a level 2 axillary dissection. However, if they're
let's
clinically
clarify. So the patient doesn't have to be clear. So if the patient is node negative, clinically node negative, and we can talk about what that means, then that's the only patient that would qualify for a sentinel node. But I'm not saying that patients who are clinically node negative can't get a level 2 axillary dissection, because not everywhere have sentinel lymph node biopsy available as a technology. So even if you're clinically node negative, it doesn't mean you must get a sentinel node. It means you qualify for a sentinel node. And if you have all things available, you probably should access the minimally invasive option. But not all things are available all the time everywhere. So anybody can get a level 2 dissection, node positive or node negative. But only node negative people can get a sentinel lymph node biopsy.
Okay, and additionally, you were saying that if someone qualifies for a sentinel lymph node biopsy, meaning they were node negative, and we did the sentinel lymph node biopsy and it was found to be positive, you're saying that we don't go back to take any more nodes because there's no benefit?
Exactly what I'm saying.
Okay, I understand. Thank you, Doc.
Doc,
Hello?
Hey Doc, I have a question. So I just wanted to know if stereotactic breast biopsy and the hooked wire local excision is the same thing or they're two different procedures?
There are 2 different procedures. So with a stereotactic biopsy, so with a hook wire, all we need to do is to put the wire in. It's a very old technology. We can identify something on ultrasound. We stick a wire into it, and the surgeon basically uses the wire as a guide, dissect down towards the end of the wire and take out what's around the wire and send to the lab for testing. Just to make the point that the correct way to do it is to take out the lump and send it back to the radiologist for assessment. Once you do a hook wire, you take out the lump and you send it back to the radiologist for initial imaging to say that, aha, yes, you have the lump. Or, no, you missed the lump on the deep margin, or you missed the lump on the left margin or the right margin. So you have to orient your specimen, right? And then once you've gotten the lump, you go back, you send that to the pathologist. So it's sent fresh back to the radiologist for imaging and then fixed and sent to the pathologist. So you have to have a certain amount of systems in your hospital to be able to get that done, or it becomes too complicated. With a stereotactic biopsy, there's no wire. You have a mammotome, which is a mammotome is almost something like a core needle biopsy, but it can fire multiple times automatically. And you can identify the lesion on imaging, put a mammotome in there and just fire, and it basically cores out the entire tumor. So we can do stereotactic biopsy if we have all of the tools. But it's not the same thing necessarily as a hook wire localization.
Okay, thank you.
All right, after run compatibility rounds are gone, it was a pleasure having you guys. It was a lot of fun.
Thank you, Dr. Paul.
Thank you, Doc.
Good luck.
Thank you,
Good
Dr.
luck to all
Paul.
of you. Bye-bye. I'll
Thank
see you
you,
next time.
sir.
Recording stopped.